I'd like to give you a little bit of an overview of who the TA Center is and what we do. Since 2008, SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center has held 8 policy academies and 6 implementation academies. We cover several topics, including suicide prevention, substance use, and justice-involved veterans. We also serve 49 states and 4 territories in the District of Columbia through these activities. As you can see on this map, there are 49 states and 4 territories that have taken part in our Policy Academy process and Implementation Academy process. We work with teams across the country to gain a broad perspective on emerging trends and best practices for service members, veterans, and their families. We work to connect our teams to national experts like those here on this webinar and share lessons learned across states. We also offer a variety of technical assistance opportunities, including learning communities, site visits, webinars, and other academies. We're here today because we're looking at building networks of support. We really know that supporting the behavioral health of SMVF takes a whole community. We know that partnering with veteran service organizations and other veteran initiatives ensures that the network of support in your community is stronger. And we also know that veteran service organizations have evolved over time to address the behavioral health needs of today's SMVF. Our objectives today are to describe the role and the mission of our presenters' organizations, the Student Veterans of America, the Cohen Veterans Network, and the George W. Bush Institute's Military Service Initiative. They are among many veteran service organizations that work to improve the behavioral health of service members, veterans, and their families across our country. We're going to explain new programs and initiatives that have recently been launched, as well as identify ways that stakeholders can support and partner to support the behavioral health of SMVF in their community. We also want to discuss successful strategies to strengthen our networks of support at the national and local level, which is so important. I am pleased to let you know that, I actually wanted to let everyone know, I'm not pleased, that Cicely Burroughs-McElwain, she is the project officer for our TA Center. She was going to be here today to moderate, and she was called away to work on relief efforts for Hurricane Harvey. And she sends her regrets, and we also want to take a moment to recognize all the hard work that's going on in the relief efforts for Hurricane Harvey, and recognize the trauma and all of the terrible things that have happened with the people and the families of Texas and Louisiana along the Gulf Coast. Now I'd like to transition and move on to introduce our first presenter. Mr. Barrett Bogue is the Vice President of Communications at Student Veterans of America. He is the nation's leading voice in supporting America's veterans through higher education. For nearly a decade, Mr. Bogue has led public campaigns promoting the largest expansion of education benefits for veterans since World War II. He is also a former Marine and a Presidential Management Fellow. Presenting along with Mr. Bogue is Mr. Dan Standage. He is the Director of Disability in Education at Student Veterans of America. He is the National Authority on Disability in the student veteran space. His experience as a Marine, Student Veteran Chapter Leader, Student Veteran Resource Center Director, and Project Coordinator for Congressionally Directed Research on Veteran Integration provides a level of expertise that is both unique and valuable. In his current role at Student Veterans of America and as co-chair for the Head Veteran Special Interest Group at Association on Higher Education and Disability, he is working to change the landscape of disability design in higher education for veterans. Welcome, Mr. Bogue and Mr. Standage.
That's great. Thank you so much for that kind introduction. Again, my name is Barrett Bogue, and I'm VP at Student Veterans of America. If you could go to the next slide. Before I turn it over to my colleague and good friend, Dan, I'm just going to spend about 5 minutes talking about SVA, about how we came together and became the nation's largest student-led chapter-based organization. I'll show you a little bit about who student veterans are, how we support them as chapter leaders, and go over our partners and resources. And then I'm going to turn it over to my colleague, Mr. Dan Standage. By all means, as Dan and I talk, feel free to submit questions. Within the webinar platform, we'll try to answer them to the best of our ability at the appropriate time. Additionally, I think we do provide our contact information at the end of this slide deck, or at least our slide presentation. So, why don't we go ahead and get started? Next year is going to be a big year for SVA. Next year we will celebrate our 10-year anniversary. So approximately a decade ago, after Iraq and Afghanistan, the student veteran community came together in 2008 and established Student Veterans of America, as well as our first annual conference. And since then, SVA has grown to encompass chapters and campuses across the country at approximately 1,500 schools. So we are the nation's largest student-led chapter-based organization in higher ed. And every year, every January, we host an annual conference where we have between 1,500 and 2,000 student veterans attend. We do represent the 1.1 million veterans in school today using the GI Bill, and that takes form in many different ways, including programming, including our national conference, including the most recent policy victory that we had in passing the Forever GI Bill. If you're not familiar with it, it's a major change in how the GI Bill operates. We successfully enabled student veterans to use the GI Bill and turn it into a lifetime benefit. Thus, that's why we call it the Forever GI Bill. It was recently passed in Congress and signed by the President this summer. So there's no longer a time limit for veterans to use their education benefits. They can use it at any point in their life. So, next slide, please. Who are student veterans? Well, you may be surprised to learn that student veterans are not traditional students. In fact, they align more with non-traditional students in higher education. Almost half of them have children. 80% of us are over the age of 25. We very much prefer to attend public schools of higher education versus for-profit schools of higher education. And our population report that 90%, an overwhelming majority, are prior enlisted. So what we see is a very strong propensity for prior enlisted service members to continue a second service, if you will, in higher education through the transformative power of the GI Bill. And as you see this and as you look at this data that we collect at Student Veterans of America, you can understand why we felt it such a call to make the GI Bill a lifetime education benefit, because clearly education shouldn't be limited within a 10 or 15-year time frame. It should be at any point in time in your life so you can support your family, so you can support yourself, etc. So how do we support students as chapter leaders? Next slide. Again, we have a chapter of over 1,400 schools. Right now, current count is 1,455 active chapters. We represent on those school campuses approximately 600,000 student veterans. We want veterans to be informed consumers of their education benefits. We invest in high-impact programs to help them become the leaders of tomorrow, and we provide our service through chapter support. So here at SVA HQ, anytime we get a call from a student veteran who needs help improving their chapter, learning how to fundraise, help in choosing a school, etc., we fulfill that need up here at SVA headquarters. Next slide. In addition, we provide a wealth of partnership and resources, and this is really just a snapshot. Veterati, we host a mentorship platform where we connect student veterans with mentors in any industry of their choice, where they can meet weekly, bi-weekly, and establish that mentoring relationship. College Factual, we partner with College Factual to offer support in choosing the right school as well as choosing the right major based on your interest. Those are just a couple of the resources that we provide to student veterans. We also provide them support in finding meaningful employment. We help them develop their resume. We help them develop their leadership ethos. So if you're looking for ways to support SVA, if you've got a program, if you have an opportunity that helps support the student veteran life cycle to, through, and beyond higher education, we're definitely interested in hearing about that. So the next slide, please. In addition to supporting student veterans, we tell the story. The story of student veterans is a rich, diverse history of human beings who have done wonderful things for our country and continue to do so. We honor that diversity year-round, and every month we tell a story about a student veteran or more to celebrate events like Women's History Month, National Volunteer Month, Mother's Day, Father's Day, LGBT Pride Month, Black History Month, etc. You can go on our social media accounts. I think we link to them, and you can just see the incredible diversity of our student veteran community. Next slide, please. Finally, I know I touched on Forever GI Bill. That's not the only policy proposal that we have. We also empower veterans, and we partner with the VFW to host 10 legislative fellows, where we bring them up to DC every spring, where they can meet with their Congress members to advocate and eventually implement a policy priority that they may have. Next slide, please. Groundbreaking research. So if you're interested in learning more about some of the data that I've discussed, no one does peer-reviewed research into student veterans in higher education and federal benefit programs like Student Veterans of America. It's really what sets us apart from the other veteran organizations. You may be familiar with our National Veteran Education Success Tracker. That's a cohort study of approximately 8 years of post 9/11 GI Bill veteran students, and we measured how well they succeeded academically. And the results were that student veterans, when compared to their peers, the non-traditional students, perform better academically. They're more likely to graduate from school. They're more likely to earn a degree in a high-demand field. They're more likely to have a higher GPA. And if you're interested in learning about our research, if you're interested in contributing to our research, you definitely want to check out the website that we have listed there on the slide. Finally, next slide, please. Our big premier event takes place every January. It's our annual national conference. This year it's going to be in San Antonio. If you want to access, influence, meet, speak to, and network with student veterans, it is the nation's largest gathering of post 9/11 veterans who just happen to be awesome students. I've got the link right there. If you're interested, if your company or organization is interested in presenting, if you're interested in attending, definitely visit that link to learn more. Okay, I just put a lot out there. I appreciate your time and attention. I'm going to turn it over to Mr. Dan Standage, and we place an emphasis at SVA in supporting student veterans living or diagnosed with a disability. And that starts with Dan and his full-time support in that endeavor. So thank you so much for your attention. Dan, please take it away, sir.
All righty. Thanks, Barrett. So I'm going to go ahead and take it to the next slide. Okay. So right now we're working on adding a third campus contact to our arsenal by way of disability services. This point of contact doesn't currently exist in a database anywhere. I went all the way up to the Department of Education, and everybody that I know to find out if there was something that existed already, and there wasn't. So we started building the list ourselves. We're a little over halfway in identifying the contacts at campuses that we have an SVA chapter at. So of the 1,500 or the 1,455, we have approximately 730 that are identified. It provides a really unique channel, again, that nobody else has. And every time I mention it to somebody that's in the space, they always ask me, when you get it done, please let me know, because that's a really important one. Right now, Department of Labor, Office of Disability Employment Policy is currently interested. And what it does is it gives SVA insight into interesting trends, such as particular strengths that the disability services may have or the campus in general. Another example of that is there might be a really strong counseling component to a particular school that we can identify and spotlight and then model that to try to get it spread across the country. Next slide. All right, so this is just a map that shows all the SVA campus locations, the chapters, and the yellow ones have a disability point of contact identified. So we have, again, about half, and that's what it looks like visually. There's a couple of other locations that are off the map that are not in the United States, like Guam or Puerto Rico. But you also might be wondering what those blue pins are, and I'll get to that a little bit later. So next slide. All right, so I want to talk to you about some research that we do at SVA that's really unique. We conduct an annual census survey. It's usually every October, and that's directly out to our network. So we have the most current information about the student veterans that are currently attending school. And we like to get their feedback because it informs us on what we're doing and how we need to change every year. And we've been looking at disability angles. So some of the questions that we ask about their disability. So good stats, more than 57% have a VA disability rating, are waiting for a VA determination, or are in appeal with the VA. That 57%, 51% of that, those have a disability rating. And you might be asking the question, well, what is their disability rating percentage? The majority of them is 50% or greater. So again, significant disabilities, not just a little ringing in the ears, a little more than that, and comorbid occurrences of disabilities. Of those who reported having a disability rating, 80% stated that their disability caused them some level of stress, and that is a red flag for us because we know that if a veteran is complaining about some issue, that it takes a lot to get that point across to everybody, and so we're paying particular attention to that. Next slide. So the Disability Services Liaison is something that we created. Those are those blue pins on the map. Those blue pins represent 15 pilot sites currently going on this fall, and will expand into the spring as we hit phase 2. It's a servant leadership opportunity for student veterans to become a VA work study and get paid by the VA to help other student veterans basically get in contact with their disability services and also other underused services that are on campus. And it's an effective, no-cost veteran outreach program for schools. So they get the benefit of it doesn't cost them anything, and also it helps veterans show up at those underused service locations. There's a DSL toolkit for a turnkey solution, so they don't have to think about what they need to do. We provide all that information, and we provide all the training. We use a little program called Slack to give them effective communication, so they've always got an instant-on communication directly to me, and then we push out information directly to them. And then the very last thing I want to leave off on this slide is that it's about normalizing help-seeking behavior for veterans. It's a difficult concept for them to understand because they're not acquainted with disability going into the military, and when they come out in an academic environment and when they go on to employment, it's really, really important that they're comfortable in understanding the difference between disclosure and identity within disability. So the next slide should be your contact information. And it's a great way, sorry, one more slide. There we go. So that's our contact information if you want to stay in contact with us. Thank you.
Thank you, Mr. Bogue and Mr. Standage. That was really informative, and we did get a couple of questions, so we'll hold those until the end. Next up, I would like to introduce Crystal Shelton. She is the Vice President of Clinical Programs at Cohen Veterans Network. Ms. Shelton is responsible for the development and day-to-day oversight of clinical programs, including clinical training, telehealth, clinical innovations, intern and scholars programs, and works directly to support each clinic to have the clinical resources and expertise necessary to provide the highest quality clinical services to our veteran and military families. Ms. Shelton also served as an active duty social work officer in the United States Navy. Welcome, Ms. Shelton. I'll turn it over to you.
Great. Thank you so much. I'm really excited to be here to talk about the work that we're doing and really how it is that it ties in with the theme. You know, when we talk about building networks of community, it's really foundational to what we do to work with our community. So it's really a great opportunity to talk to everybody here, introduce our network to those of you who haven't heard of us, and to just begin engaging with our communities across the country for those of you who have. I want to start by introducing our organization a little bit, just the history. It's incredibly important that people understand we were founded through a really generous gift by Mr. Steve Cohen, who set aside a large sum of money, and his son had been a Marine. When Josh came back, Steve was looking for a way to help support veterans, and Josh said, you know, if you really want to help veterans, there are unmet needs within mental health, and not just through the types of services that are available at the VA and through the CBOX, but also really there's a lot of people out there who have bad paper discharges who don't have access to care. There are family members who don't have access to care, and outpatient mental health services are really wanting in this community. And so Mr. Cohen set aside his gift, and we have been building our network of free to low cost outpatient mental health clinics ever since. All right, so next slide, please. When we set up a clinic, and we have currently 7 operational clinics, and I'll show you the map in just a moment, but when we do this, the process really is a community-focused process, and so we have a very good relationship with the VA. We have, you know, we use all of the data as far as what communities can best be served, and where is there I don't want to say a shortage, but access to care issues. And again, we serve, and I'll go into our model a little bit more in a moment, but we serve veterans irrespective of discharge status, but we also serve military families, and including couples, family counseling, and children in comprehensive outpatient care. I say comprehensive, I should be careful here because we don't do IOP programs. We do comprehensive outpatient, including psychopharmacology and psychotherapy services. And so to set up a clinic, we identify a community based on available data, based on info from the VA, based on a number of outreach efforts that we have in place, and recognize where these communities in need are. And obviously there's probably several more communities in need that than we will ever be able to get to. But our intention is to get as broad of a reach as possible. And so if we identify a community in need that we could be of service, and we work then within that community to identify a partner organization. And I think that this is a really important part of our mission and organizational structure. So we aren't going in and building bricks and mortar ourselves. We have clinic model and we have funding, but we think that it's very important that within every community we enter into, that we work with a partner organization that knows that community, that's integrated into the community. And so we go to that community. We host a series of roundtables. We work with veteran service organizations on the ground. We find who has the credibility and the footprint, the capacity, and the motivation, passion, and ability to help carry forward our mission and open a clinic and staff a clinic and operate a clinic according to the principles that we've outlined as being important. So that pre-opening process, you know, it really is, we focus on the data, we figure out what the community needs to look like, where we need to go, what a potential partner organization might be. In some cases, in some communities, we meet multiple potential partner organizations, and we work for a long time to really figure out who that ideal partner is. In some cases, those partner organizations have been academic institutions. In some cases, they've been healthcare organizations, hospital systems. In one case, it's in our Dallas clinic, we worked with the county. And in San Antonio and Killeen and El Paso, it's a veteran service organization that had not previously done outpatient mental health treatment. And so there's a very diverse group of people that we feel have been successfully able to do this with us. And so when we look for partner organizations, it has so much more to do with, is this somebody who's already operating mental health services? All right, next slide, please. So what is it that we do in a clinic when we open it? We offer free, no cost to free mental health services. And when I say no cost to free, we are in the process for our sustainability looking at managed care. So there could potentially be the opportunity to offset some costs and increase sustainability over time with things like co-pays. However, I want to really emphasize that the importance here is on eliminating barriers to care. And so there will always be an ability for somebody who needs care to get care, period. We have confidential services. We see veterans, military family members, which can be in, you know, as the service member defines them. So we see partners, we see parents, we see children, we see close friends, caregivers. We have part of our mission and our mandate is that there are short wait times to receive care. Most of the people who call can receive an intake within 24 hours, although a lot of times, obviously, that is dependent on the person's schedule themselves. But we have an innovative model that each of our clinics is staffed to do intakes very quickly, and we require that they do not, none of our clinics get so overwhelmed or create wait lists for care for post 9/11 veterans. Like we have a very strong belief that long wait times have really negatively impacted a lot of people's not just outcomes but beliefs about the value of care. And so if we can get people in the first week as long as they're ready and wanting to come in, we really think that this is how the model has to continue to work. So we ensure that our clinics are staffed to provide access within a week if that's what the caller is requesting. As I've mentioned, we see our clients irrespective of discharge status and combat experience. We use evidence-based therapies, and I'll talk a little bit more about the kind of therapeutic approach that we use in our clinical model. But within our clinics, we also are staffed for case management, outreach teams, and that's really important because, you know, you can't be everything to everyone. And so we cannot be an employment agency, and we cannot be a housing agency. But we know that these things are tremendous barriers to care. We know that some of our clients can't get transportation or child care. And so we have resources, both financial within the clinics, but also, you know, we really, like I said, focus on integrating within our community, build strong case management and outreach teams so that any barrier to care, we are staffed to make sure it is addressed early at the intake process. And so once we get clients in the door, we want to ensure that we have a really highly competent staff. We have, during the introduction, it was mentioned that I oversee the clinical training And beyond just clinical training, we focus on military cultural competence training. We focus on ongoing military cultural competence training because, as we know, it's not a static topic. It's not a one and done. There's changes over time and understanding what, 5 years of war versus 10 years of war versus 15 years of war might mean to our military families. Things change from policy, and that has a way of impacting our military families. So what you'll find in our clinics is a team of clinicians, many of whom are veterans and service members themselves, military families, but they're also actively engaged and really committed to staying abreast of the things that are both culturally relevant and socially and politically relevant to our service members and our clients and our military families. Next slide, please. So we are currently located in New York. We have a clinic in El Paso, New York, San Antonio, Dallas, Texas, Fayetteville, North Carolina, and the University of Philadelphia, University of Pennsylvania, Philadelphia. We are soft launching our clinic this week in Washington, D.C., and very soon we'll be opening doors in our clinics in Killeen and Clarksville, Tennessee. You can see from the map where else we're planning on being within the next 6 to 8 months, and that's going to include a clinic in St. Louis. And we're also opening doors in Denver, hopefully this fall. In most of these cases, like I said, we've identified partners. All of our open clinics, we have a diversity of partners. We're still finding partners in our Orlando, Miami, Montgomery, Memphis, and San Diego, Los Angeles, and Seattle locations. Next slide, please. So the type of care that we offer is focused on time-limited therapies for a variety of treatments, a variety of issues that should come up. So the dominant issues that we see presenting in our clinics, the diagnoses are post-traumatic stress disorder, obviously, for several of our combat veterans, but we also see a tremendous amount of depression and anxiety. We see a number of transition issues and just general adjustment stressors. And so all of our clinicians are trained in a broad array of therapies. We have, everybody is trained in cognitive behavioral therapy, and several are specialists in manualized therapy for post-traumatic stress disorder and insomnia, some of the things that cause the most distress. Everyone is extensively trained in suicide risk assessment and prevention. Each of our clinics is staffed with children, the capacity to see, assess, and treat children, couples therapy, and family therapy. And again, we have case management as an option for any of our clients who need access to resources that would otherwise be impediments to care. A lot of these resources are for housing, employment, education, finance. In some cases, we're having to develop resource and referral partners for MTBI treatment, substance abuse. We don't operate, like I said, we don't operate IOP. We are limited somewhat as far as our ability to treat things like TBI. So really, referral partners are an essential part of what we do because we have to make sure that at a minimum we can do a really appropriate assessment and a warm handoff within the community or to somebody who can help us with a veteran. We want to make sure that when they walk in the door, they're getting a very high quality of assessment, and for the most part, if we can't treat them, we need to know who can. We also offer psychopharmacology support, so it is as close to comprehensive as we can get without going into like an IOP program. All right, next slide, please. Once we've opened, our case management and outreach staff are really, really busy cultivating and maintaining local partnerships, working with local partner orgs. Again, each individual clinic has local staff members that are very, very frequently drawn from either service members, veterans, or family members. And they work closely with our community service organizations. to ensure that there's warm handoffs available for all barriers to care. We have really great partnerships for training. We work closely with Center for Deployment Psychology. We work with SAMHSA, National Council for Behavioral Health. We work with a lot of academic institutions. It's important to us that our clinicians and non-clinical staff have access to professional development that keeps them excited and fresh. We all know from being in this field that it can really be stressful if you don't have adequate resources, if you feel overwhelmed. And so that's, what we hope to do with all of our staff is not only keep them passionate about the work that they do, but really feel like they have a ready arsenal and their ability to actually address the issues that they might see presenting in their clinics. And then, as noted here, we also want to make sure that we are an available resource. I've talked a lot about the resources that we draw from in our communities, but we want to make sure that our communities that we're there, they know we're there, that they have somewhere when we're present in a community. We want to be sure that we can provide access to all of the people who would possibly need care and not know that we exist. So the VA is right now the largest referral resource for the network, and we're very happy to continue serving military families as well as people who don't have access to care from the VA because of bad paper discharges or because they might need more frequent appointments than their potentially overwhelmed VA can manage at a time. So next slide. So we're really focused on growth, as obviously it's our, we're an 18-month-old org, and so as we focus really on the future, we're looking at how do we build national partnerships with other veteran service organizations for referral events, data sharing, working a lot on national marketing campaigns, national anti-stigma marketing campaign. We're focused a lot on how do we help expand training resources, and that includes, clinical training, but also training resources. We're working with SAMHSA and the National Council for Behavioral Health and Center for Deployment Psychology on a series this September for suicide prevention and going over epidemiological data and current news in assessment and prevention of veteran suicide. And we really think that working with our community, especially broad-reaching communities, I'm speaking to the choir here on a webinar, but there's a lot of people that don't have access to the training that they need to feel confident working with a veteran, especially if they don't see a lot of veterans, military family members, guardsmen. And so we want to be able to use our resources to help expand knowledge, not just within our network, but within our communities and the community at large. Next slide. Okay. So thank you so much. That's all. And no, that's great. And then I look forward to answering any questions if there are any.
Great. Thank you, Ms. Shelton. I appreciate all of the great info, and we've got some great questions that we will hold in. Next up, I would like to introduce Casey Kelly. She is the Director of Health and Wellbeing for the Military Service Initiative at the George W. Bush Institute. In this role, Ms. Kelly oversees and manages policy, operational, and programmatic efforts on veteran health and well-being, including the Warrior Wellness Alliance. She also manages strategic efforts to promote partnerships, collaboration, and alignment among organizations that are so crucial to fostering the health and well-being of post-9/11 veterans. Prior to this role, Ms. Kelly served as the National Director for Public-Private Partnerships in the U.S. Department of Veterans Affairs Office for Suicide Prevention. Welcome, Ms. Kelly. Thank you, and I'll turn it over to you.
Thanks, Angela. Good afternoon, everyone, and we can go ahead and go to the next slide. And our team, the Military Service Initiative. MSI initiative, we advocate for awareness, policies, and programs that enable warriors and their families to successfully transition. And what that looks like is we provide research, resources, that by fostering success in these areas, we enable a generation of leaders throughout the United States. We can go to the next slide. Through the Military Service Initiative, we have 4 primary program areas, one of which, and is the one you probably, you may have heard of, it's been around for the longest, is the Team 43. It's a warrior ride. It's a 100-mile mountain bike ride down in Crawford.
Ms. Kelly, it sounds like our sound has cut out for you. We are going to take a pause and see if we can get this issue worked out. Hold on just 1 second.
All right, just let me know when you can hear me. If you need me to call back in.
I actually can hear you right now, but if you wouldn't mind trying to call back in to make sure that the connection is secure.
Okay.
Thank you. Thank you to all of our participants for your patience as we try to work out this technical issue. I think while we're waiting on Ms. Kelly to come back in, I wanted to just reiterate to everyone that the slides for this presentation will be available after the webinar is over, and we'll be sending out an email to all participants with an archive link. Please type in the chat box if you're unable to hear me. Thank you. So I'd like to go ahead and start with one of the questions for SVA. There is a number of people who are wondering what states are participating in the pilot liaison program. Dan or Barrett, would you like to take that question really quickly while we're waiting for Casey to call back in? Dan or Barrett, you may be on mute. You want to try to unmute yourself? Okay, I apologize everyone for these technical difficulties. Let me see if I can try to send another question over to Crystal. Crystal, are you on the line?
Can you hear me?
I can hear you, Crystal. Thank you so much. We were wondering whether or not, what is the Cohen Network's process if you identify a person with an addiction along with their mental health disorder?
So it depends on the clinic, and this is where, again, there's different, each of our different clinics has different competencies and capacities. So at our NYU clinic, they actually have a medication-assisted treatment program, and they can offer really comprehensive care. In the event that different clinics have different resources, so we have comprehensive screening, and each of our clinics is staffed with either, a certified substance abuse specialist to a varying degree. So I'm not sure, like in some cases it's a master's level, in some cases it's a bachelor's level. But screening and referral is an essential part of all of our clinics. It just, in some cases, we are able to treat comorbid disorders within the clinic, and in some cases it's a function of a built-in referral network, and it really depends from the clinic to clinic.
Great, thank you so much, Crystal. I believe, Ms. Kelly, are you on the line? Okay, we're still waiting for her to call in. So let me see if there's another question we can ask Crystal. Let's see.
I'm a captive audience.
Yes, absolutely. So one of the questions that we had asked was whether or not there was testing for learning disabilities provided at the Cohen clinics.
So we do not currently do academic or intellectual functioning testing. We do have clinicians, some clinicians that are trained in academic testing and learning disability testing, but it is not a part of our standard model, and in part, it's really difficult to standardize that, as everyone recognizes, because there's a shortage of well-trained clinical staff who can offer that. I think we have one clinic right now that offers academic testing, academic functioning testing, but it is not a standard part of our clinical model.
Okay, thank you, Crystal. We also have a question about wondering how would people know the range of specialties by clinic? Is that listed on your website?
So I would say that with the exception of something slightly unique like academic intellectual functioning testing, the range of, I mean, every clinic may possibly have a unique program, but the standard treatment approach for all clinics is similar in that we offer cognitive behavioral therapy and time-limited treatment, including manualized therapies for post-traumatic stress disorder, for anxiety, depression, marital stressors, and children and families. I think that the safe assumption is to really just expect that that's where we excel. It's not likely that most of our clinics are going to have a lot of specialty focuses this early on, especially around substance abuse. It's really a function of having strong referral partners within the communities.
Great, thank you, Crystal. It looks like Ms. Kelly has joined us. Ms. Kelly, are you on the line?
I think so, Angela. Can you hear me?
I can hear you wonderfully. Thank you for calling back in, and I'd like to just go ahead and let you catch back up to where you were at and take it off.
Sure, and we can actually go to the next slide.
Okay, excellent.
So I left off describing that one of our initiatives through the Military Service Initiative, one of our program areas is health and wellness. The mission of the Health and Well-Being program is post 9/11 veterans and the invisible wounds of war. Those are really our focus areas. And what we mean when we talk about the invisible wounds of war, we are very careful to be inclusive of the psychological portfolio, inclusive of post-traumatic stress, substance abuse issues, depression, and others, as well as the physical insult, TBI, and its spectrum. And we know that if not effectively treated and treated optimally in the early stages, we know that warriors may endure these conditions may endure along with their association with higher rates of many unhealthy challenges and the resulting impacts on mortality and morbidity. So as of 2014, we know that there were approximately 5 million service members who had served in the conflicts post 9/11. 2.4 million still serve in either the active reserves or Guard, and there's 2.6 million who fall into the post 9/11 veteran category. Of those, roughly 15 to 20% come home with symptoms consistent with a diagnosis of PTSD. Our position remains that each warrior who comes home with symptoms of the invisible wounds are responsible for his or her own care and their own fate, and must take the essential steps that are necessary in order to seek treatment and care. However, what can we do to create or enhance the system and to influence care-seeking behaviors, and then to make sure that we provide a comprehensive and high-quality care network for them as part of their care-seeking in the system. We know that quality care is critical For example, 83% of service members who receive care for a visible wound of war, but we know that less than half of those invisible wounds also seek care. We also know that of the veterans who are eligible to get care in the VA, only about half will actually visit the VA in a given year. I can go to the next slide, Angela. Thank you. So what is unique about the U.S. and the way that our healthcare system and the way that we deliver care is that the current state of the private health system of care is highly segmented, and it can be very confusing to all of us, as well as veterans. It includes an array of healthcare providers, employers, nonprofits, health insurance companies, purchasers, health plans, the pharmaceutical industry, you know, the folks that make policy on the federal, state, and local level, and a whole host of other entities that make it confusing. So we know that there are a number of barriers to accessing and receiving care. You heard some of the other folks presenting today mention some of them. We know that these are preventing many of our warriors from connecting to the treatment that they need. And although many treatment options exist, studies have shown for the invisible wounds, less than half of military personnel and veterans who experience them actually receive any care. We also know that there are substantial numbers of U.S. veterans who rely on non-VA sources of health care, some of which are highlighted today, placing a significant responsibility on the private, community, and nonprofit providers. We also know that supplementing the formal systems of healthcare delivery for veterans with the invisible wounds is an enormous network of informal caregivers, many of whom are family and or friends who devote substantial amounts of unpaid time in caring for them. So this reality is that we have multiple systems of care, some of which are unknown in their quality, particularly in the private sector, but the largest challenge remains in getting folks connected to high quality care when they need it. An example, a statistic that sort of highlights an example, I'm sure you guys are familiar with this work. Only 13% of community-based mental health providers are ready to deliver culturally competent, evidence-based care to veterans confronting the invisible wounds. That's why you heard Crystal talking about how important that was in their clinical care delivery model. Okay, I think we can go to the next slide. So the Bush Institute recognized that this problem was complex. And in support of these observations, we have framed our efforts underneath the framework of recognize, connect, and deliver, with the warrior and the family at the center. Through this, we aim to help warriors and their family better recognize, become aware, and understand the invisible wounds of war that will then lead to improvements in connection to care through care-seeking behaviors, reduction in barriers, and leveraging the role of care-seeking influencers. In addition, we hope that the delivery will also be improved, or we aim for the delivery to also be improved. And we are working to foster collaborations to help deliver a warrior-centric network that fosters a system of comprehensive, integrated, and culturally competent and high-quality care delivery that will span across all phases of resilience, rehabilitation, recovery, and integration. The other thing that's highlighted on this slide is a recent policy paper that can be downloaded from our website that outlines our recommendations and the steps that we encourage folks working in this space to take. The intent is to bring together the multiple stakeholders within this complex system to concretely work on integrating the systems of care while spurring innovation and raising awareness. Through what we're calling the Warrior Wellness Alliance, we seek to optimize the impact of innovative, high-quality care programs and peer-to-peer veteran networks for a more effective impact on the invisible wounds of war, and to promote warrior wellness amongst post-9/11 veterans and their families. again, through this recognize, connect, and deliver framework. All right. The goals of the Warrior Wellness Alliance that are outlined here include enhancing accurate public awareness, understanding, and acceptance of the invisible wounds and their impact, advocating for research that leads to more effective diagnostics and therapeutics, improving access to high-quality care that is available, and increasing the number of warriors in effective care. Ultimately, that is the goal, to increase the number of warriors that receive effective care when they need it. At a national level, we think there's an opportunity for a more open and deliberate collaboration, and we believe that this collaboration could serve to expand the scope and scale of existing services and practices that are operating in silos across the country and promote greater care seeking among veterans. Okay, next slide. So we're really excited in February to launch the initial Alliance membership. And the Alliance membership are made up of sort of two categories of organizations. One that represents our care provider networks that we see as best in class, and the other are our peer networks that are the leading organizations in the post-9/11 veteran space. So you'll see here that our best in care delivery folks include the Warrior Care Network that is supported by the Wounded Warrior Project and includes the Emory program, the Home Base program in Boston, the UCLA Operation Men program, and the Rush program in Chicago. It also includes our co-veteran network partners that you've heard from earlier today, operating 7 clinics around the country currently with plans to open many more in the future, as well as the Marcus Institute for Brain Health, TriWest Healthcare Alliance, which operates in 28 states and has 25,000 mental health care providers, and of course the VA. In addition to these, we've had preliminary conversations with other federal partners such as SAMHSA to identify how we can get down into the state and local level. And then finally, we're really excited about engaging with our peer network that through these organizations helps us touch and inform and educate approximately 1 million post-9/11 veterans. Then I think the only other thing I want to just say is the Alliance is one example of what we're doing through the health and well-being programs at the Bush Institute to help post-9/11 veterans access better mental health care more efficiently, more effectively, and for us as a country to optimize the resources and organizations that have been started in support of them so that we work more collaboratively to end post-9/11 veteran mental health challenges. Okay, I'll stop there.
All right, thank you, Ms. Kelly. I really appreciate all that great information, and I do apologize for the technology issues on this webinar. But I just want to let everyone know that we have run out of time, so we won't be able to take the questions and answers right now, but we'll try to address them after the webinar via email. I just want to again thank Mr. Bogue and Mr. Standage from the Student Veterans of America, and Ms. Shelton from Cohen Veterans Network, and again, Ms. Kelly from the George W. Bush Institute. Thank you for all of your insights, and thank you everyone for participating in this webinar. I hope everyone has a great afternoon.